Dear friends, we are continuing the Everything I Know series with the Biotensegrity archive, where our host and guest and star is Dr. Levin, and we already covered a lot of the journey, a lot of the different ups and downs into it, and I think that really the most important thing is to understand that the whole journey was rather organic, I would say. There wasn't much of that sort of, I got the super big idea. It was, once we see the journey, everything, the dots really getting connected, and it comes in a very natural way. And in the previous episode, we discussed the 1980s, your total activities with the American Association,
North American Association of Manual Medicine.
And the osteopathic community, once it got accepted into the United States as they're on par with the MDs. So maybe today we will get a little side note or the side dive and start in a rather concrete way. So here we have a pile of books which you have one way or another contributed to, and we might just take this kind of book skimming, to say so. Just get some of the histories attached to these books and what's in it and what's behind it. Let's put it like this. So the one which was here on top of the pile, that's Musculoskeletal Medicine, the Spine. So if I'm handing the book to you, just let's test your memory. What?
It is John Burns and Lois Burns and John Patterson. They were two actually MD manual medicine physicians in England. Wrote a book. I knew them through FEM, the International Federation of Manual Medicine. I have a chapter, I believe, on the cervical spine. But anytime I wrote anything, it was always related to the biotensegrity concept. But this is actually pretty early. I'm trying to get you a date on this. 1990. This was published in 1990.
So that means that the book went into the making in 1988 or something like this.
Right, and I knew them through the 80s, as I said, mostly through the International Federation of Manual Medicine. And actually, I knew Lois Burns for many years. I stayed in his house several times.
You mean back in England?
In England, yes. And he stayed here. He visited here too.
And what would be the sort of, if you recall, what was the drive there? Because the cervical spine, if anything, actually the cervical spine comes up for the first time in our conversations over the previous episodes. So it was mainly the lumbar, there were elbows, there were wrists, but not so much on the cervical spine. So any interesting accounts that you would want to share with our viewers?
Well, it was mostly just, again, it's when you start thinking about tensegrity, the model for the cervical spine has always been, again, this whole lever system. Mm-hmm. But we know that...
The head like a bob, which sort of counter weight.
Right, but in order for you to have your head suspended on a long series of chain links, essentially, you need a mass sticking up there quite high, and we don't, so usually you think of the spinous process of T1 as giving you a height, but it really can't give you very much, so the lever forces would be horrendous. And if you think of a bird, for instance, or a chicken, and a chicken neck, it just doesn't make any sense at all. So when you put it into this structure, you can have it bent in that direction, and it's not a big problem.
Okay, so in that respect, when we come to the cervical spine, it also connects us back to your early inquiry into the dinosaurs.
Oh, yes.
So where the logic is that, okay, the human head might not be that super heavy, so you can kind of get by with the calculations and say, you know what, we get the attachment here at the C7 and T1, and that's why you have the big, the relatively big prominence of the spinous processes. But when you take the model further and say, hey, if we start scaling it up, the actual moment arms for the head, and at the same time the weight of it, there are computational questions which surface up.
It's more than just a question. It becomes illogical.
So whilst the application, I would say, of the tensegrity model to the cervical spine comes with the scale-free and kind of weight-free distribution. Yes. Am I correct in that?
Yes. It's a truss system, but it's an omnidirectional truss system. So it's like building a truss bridge that spans this region, and he can do it. And you can't do it with the lever system. It just doesn't work.
Okay, so, I think that one of the things that we will kind of get in respect to 2020, right? So you see the day and age of being nice and polite and sort of having this open, soft applications, we would say that, well, the fact is that definitely if you massage the math long enough, you can still kind of get to fit a lever here and there, but that's really, you need to do some serious massage, and it doesn't really follow the system science principle that it has to travel easily through the scales back and forth.
And it's not an energy conservation concept. And the body's always looking for the easy way out.
So this way we're returning back to the things that you actually pointed out right back here in your first paper, right? So the triangulation, the compact, the close packing, and the minimal energy requirement.
Minimal energy is a standard concept in any systems computation. You're always, if you have a systems going, it's always going to seek its lowest energy level to function.
Well, but what would you say if we were to kind of link your decades of experience? How would you say that this cervical spine perspective might influence the practical choices? The practical choices in the examination of the spine, the practical choices in the examination of the cervical spine, all the way, like up to the cervical cranial connections, and when it comes to the evaluation of the imbalances and the manual interventions, or general rehabilitative interventions there. So any tricks of the trade or any sort of interesting insights that you would be willing to share?
My experience is there is an orthopedic surgeon alive who thinks of the spine as being a lever system. He just doesn't think about it unless he's asked specific questions about the mechanics. But from the clinical point of view, he treats it as a system that's more like a tensegrity system. He just doesn't recognize it.
So kind of looking for the tensional continuity.
Right. And well, to them, they think was bone on bone. So as from the orthopedic standpoint, if you have problems with a joint, then you want to fuse the joint. So they'll fuse sections of the spine. They know that the more sections you fuse, the more problems you're going to get into afterwards. So they all realize if you make that stiff, you're going to get into trouble. But very few of them go back to the basic science concepts of this being a long lever system. it's just not thought of that when, as I said, the whole biomechanics seems to be separated from clinical experience.
So if we are getting back to the experience as like really hands-on experience as the orthopedic surgeon, and I think that that's an important part even for the listeners who are in the manual medicine there, right? I think that when you read the biographies or the kind of the first-hand accounts or the interviews with the orthopedic surgeons, essentially it comes down to this. It's like whether to slightly elongate or whether to tighten and so on. Even the terms themselves, it's like tighten, loosen, connect. So it's actually first and foremost comes as a tensional perception. Am I correct in that?
In a sense it is, but from the orthopedic surgeon's point of view, they end up as they only really have one good tool, and that's fusion. So what they're doing is they're usually going to stiffen one section.
Mm-hmm.
So from their standpoint, they're given this model of a stiff spine, and so they're fusing a joint.
Mm-hmm.
But when they think of it clinically, they think of everything being tension to hold it together. Mm-hmm. So the model they have, when you look at the model, is like a
column.
Yeah, like a column, like a signal tower that you have up there that has these guide wires.
Mm-hmm.
Yeah, everybody knows this very thin column that you have for the signal. Can't stand up alone, so you have the guide wires.
Yeah.
Well, that's the way they envision the neck, that the muscles in the neck are acting as guide wires, tensioning the whole system.
And that's sort of this pyramid-like shape of a neck is a natural visual aid for this.
Yes, and because you have the bulk of the neck as compared to the relatively thin column within it, that's what they would envision it as all the muscles acting as tension guide wires holding up this thin column.
Mm-hmm.
And if there's a weakness in the column someplace, they fuse it. Or
Mm-hmm.
if there is a joint that hurts or a herniated disc or something like that, they are fusing that column. But the main concept of how their neck is being held up is by this tension system.
So in that sense, we are again in a very interesting territory there, right? So that on the one hand, the fusion might be seen as the stacking of bones, and then kind of fusion sort of fits partially, the mental picture fits into the stacking, but at the same time, that's the guide wires mast model, which sort of being in between. On the one hand, it doesn't really fully depart from the compressional model. Okay, it's like, okay, it's a compression column model with the guide wires reinforcement. But on the other hand, we might say that, well, if you look at this model, then the tensional component in it really becomes dominant, right? So, and once we get more of the tensional component, that brings us closer to this mental switch into accepting the larger and more consistent tensional leads, or the model with the tensional lead and the tensional consistency, which is the tensegrity, or the model of tensional integrity.
Well, that's what I did, is I recognized how important the tensional component was. And since I knew that if you're bending the spine and twisting in all directions, you can't have it as a rigid column.
Mm-hmm.
And this allows for those kinds of changes in a tensional model with the rigid sections sort of floating within it. So
great. So that's exactly the point. So in that respect, for yourself, at least what you are saying is that you can look at the same model, at the same anatomy, to say so, right? At the same anatomy, at the same act of fusion, but at the same time, instead of looking at it as the reinforcement of the column, you can actually look at it as changing the configuration of a strut, which is embedded into the tensional continuity, and looking at the way how that particular strut would affect the whole sort of complex of the tensional ensemble around it.
Yes.
So that's again an interesting thing, that once we even take the most routine procedures, we see that instead of the one dominant interpretation, they actually have two facets to it. So the other line that leads us more towards the tensional, integrative tension perception of the body. Am I correct?
You're correct, and that's what started happening to me with surgery, is that I was still doing surgery during this point, and I would have to reinterpret all sorts of procedures that I was doing.
In the tensional integrity way.
In a tensional integrity way.
Okay.
And I would do that. I would change I may be doing the same surgery in a sense, but I would look at what I was doing a little differently and understanding it a little differently.
And that would still affect the way, because at the end of the day, not only you're doing the fusion, but you're also blending, you are still playing with the attachments and what you are actually, where you are stitching and how you're stitching and so on, so that the whole balance of force is there. You would, depending on what's in your mind's eye, it would be quite a different picture there. So how you would do this fine idea, the nuances.
Yes.
But at the same time, you were also the manual practitioner. So how do you think that influences their manual perspective on the cervical evaluation or the physical examination of the neck and so on?
Well, it flips it over a little differently, because what a orthopedic surgeon would see as a restriction and causing the problem, and it's moving too much and we have to restrict it more as a joint that's injured.
Mm-hmm.
So
it's installing the extra constraint.
From the manual therapist point of view, you're freeing up the restriction.
So that's these are the two different perspectives here. So that's a very good point.
So that when I actually stopped doing cervical fusions, because I find that I could free up the restriction much better than I could stiffen it. And there were complications of fusing a joint that you didn't get when you do manual therapy to free up a joint.
Mm-hmm. So, but that would be the same or different, or what would be your, any tricks of the trade, any nuances on how you were evaluating the neck, cranial, cervical, center, cervical, cranial?
I would do the same evaluation, except I also do a more thorough and more nuanced manual therapy examination.
Mm-hmm.
An orthopedic surgeon is examining a spine rarely lays the patient down.
Mm-hmm.
They're sitting up and they turn their heads this way and that way, and so you do a whole slew of things when they're sitting up, essentially. When you're doing a manual therapy examination in the neck, you do some of it sitting up, but then you get the patient to lie down and you're holding the head and essentially having the muscles in the neck relaxed, so the tension elements are less of a constraint, and so you can actually do a better examination of the joints.
Okay, better examination of the joints, so you kind of get deeper rather than more superficial.
Right, you're getting deeper, so that when you're up and moving the head around, you're examining the whole neck as a structural working.
Yeah, but one might say, well, isn't it an artificial thing? When the person is sitting, that's where we get a more, functional interpretation of what is happening, and with the gravity in action and so on.
Right, but what's stuck in it may be a joint that's restricted inside the neck that's preventing this total functional unit, and if you can free up that one spot, then you can get the whole neck to function properly.
But you see, what I would also want your opinion on, because if we are looking at the tensegrity system, which is being omnidirectional in that sense, as opposed to the system with the guy wires, which would be going from top to bottom, so effectively, if we just follow the spirit of the model, right? So you see, we're saying, okay, we're taking the spirit of the model. We don't know anything from the clinical perspective. We're just saying, okay, in the Guy-Wires model, the holding balance would be based on the attachments at the bottom. So if the neck is up, if the head is up, then you have the broad base of the shoulders, and so everything anatomically that actually fits into this, like plate.
Right.
So that would be those would be the leading factors that are responsible for the control. Now, when we are looking, and in that sense, it would be actually even more superficial, because the thicker and stronger guy wires, they would be going towards the broader base,
right,
and they would be wider. Now, if we're taking the tensegrity perspective, then it's the omnidirectional thing. So that means that at the very least, we have to give the equal weight to the both directions. So the head towards the neck, right, and neck towards the head, right, top to bottom and bottom up,
and inside out and outside in.
And that's right. So how would that influence the actual interpretation clinically?
From the clinical standpoint, when you're doing manual therapy, you're working at a much deeper level at the minor movements of the joint.
We can call them the milli movements, right? If the milli movement, right, speaking of the scale at the millimeters.
Yeah, but no orthopedic surgeon would examine a knee with the patient standing on it.
Mm-hmm.
They lie them down and they work the knee around, but they examine a neck with the patient's fully upright position. Doesn't make any sense. You got to.
Okay. But at the same time, especially if we talk about today, the MRIs and the CAT scans and so on, they are taken in the horizontal position. So
but there is very little correlation with these little changes that are on CAT scans and MRIs and neck and back pain. It really is very little correlation. You can have an abnormal MRI and be pain-free. You can have terrible pain and have a normal MRI. You have a bad MRI and do surgery on it and fix the pain, but you go and the MRI looks the same as it did as before surgery. So you can't go by the X-ray studies. And as we've gotten better and better with those studies, we can find more and more minor variations and changes, but it doesn't always seem to affect the
so what you're saying here in summarizing is that compared to where you were in your clinical practice, say 50 years ago, like before the MRIs and with those kind of murky and blurry wet film X-rays, and what we have today, the contrast in the observation is drastic, right? So you see, like, the visibility is dramatically better.
Right.
But if we look at the clinical outcomes, one cannot say that there has been an equal and comparable breakthrough in terms of the clinical outcomes, right?
That's correct.
And I would say that the proliferation of the entire field of the manual bodywork practitioners who actually treat this particular kind of patients is indirectly a proof, because if the things were really down to the pathology at the MRI observable level, it would all be like the success rate of the orthopedic surgery would have gone through the roof, and there would be no breeding ground left for the body workers, right? So if we are really putting it this way. Okay, but I see. So therefore, as a minimal takeaway here, we can say that the neck is a good example there, where we start looking and putting with the tensegrity model, we put on equal footing and give the equal weight to examination that goes bottom up and the top down and in out and outside in.
Yes.
So in that sense, we basically inviting the clinician to look at those factors and accepting that those factors might be equally or more important than the ones that are actually fitting into this model of the wide base, right, and the strong guy wires around it. Okay, so that's
There's a book over there you ought to pull out called Toward a Unified Ecology.
okay. We actually had a look at it yesterday already, but we would be happy to get back. This is Timothy Allen,
Yes.
Columbia University Press, Complexity in Ecological Systems.
Well, since we're talking about the body, and tensegrity concepts, you think that the only application is in the medical field.
Mm-hmm.
And the only way, that you have to be a biomechanic to understand all this. Timothy Allen is an ecologist. He's
Ecologist from the the ecosystem. Yes.
From the ecosystem. Well, he's recently retired. He was a full professor at University of Wisconsin. I was actually in touch with him not just a month or two ago. And he wrote this book with Tom Hoekstra, published in
92, I think it was.
Probably in 92 or someplace or other. I had been working with him in system science.
Yeah, that's what we...
And he was the person who really taught me the basics of system science. And we discussed it in length. And he was writing this book, and he contacted me while he was writing the book, and he said, "I'm going to put a section of your work in here, and could I use your illustrations that you use that you've shown?" Because I had done, he had seen my slides, he wanted to use.
But by the way, those slides, you made them yourself?
Yes.
So how that was before the graphic programs?
Oh, yeah.
So how did you do it?
Draw it. You make a line and draw.
You mean the pen and pencil on paper?
Yeah. But a lot of it was pen and pencil on paper. Some of it is, some of it's that.
So you mean these illustrations, if we look at Levin...
I think he cleaned them up somewhat for the book, but
Okay.
yeah. But the thing about this that I said, Tim, why are you including me in your ecology book? Because he goes from the pond water all the way up to lakes and oceans, and he says, you're talking about the ecology of an organism.
Okay.
And he says, and it's not any different to him than the ecology of what's in a pond, the little bugs that crawl around and the balance of the air and all that. So he says, you're talking about the structural ecology of an organism. And he thought it was important to include that in the book. So he included 10 pages on biotensegrity in his book on ecology.
So this icosahedra,
That's mine, yes.
That's all drawn by you?
Yeah, I think I had help with this one. I drew that one.
Wow.
And most of the others I drew.
Okay.
I drew that one. And
you mean that one?
This one, and that one. Yeah,
okay.
But most of my, as I said, he may have cleaned them up, or we had somebody clean them up for a while.
So that was in the days of the pen and paper?
Yes.
Wow, that required some
time.
Some painstaking thing,
Yeah, it wasn't particular skill, but it was time.
Okay, I see here. Okay, that was a projected image here. The ulnar radius and the wrist model. I see.
Right.
So that was. So actually, I didn't see you using this type of slide lately, but that was.
That was illustrating the kind of thing, showing that shoulder, elbow, wrist.
So historically, that kind of brings us back to the Grant's method of anatomy.
Exactly. This is more consistent with Grant's model of the arm than anything else.
I see. So that's kind of bringing us in both directions. On the one hand, we're seeing how this sort of practical type of the illustration is showing in the book, but on the other hand, indeed, looking at the ecology, looking at the organism itself as the ecosystem, and once we get into the ecosystem, right, so you see that's where we have to deal the same thing. There is an energy input and output, and the throughput, and the bottlenecks, and the bandwidths, and all these factors.
And the closed system with interactions from the outside world. And
So what defines it is actually the borders of the being the actually interfaces.
yes, the interface of the system.
So that's but it's really great to see that this bigger perspective that the organism seen as part of the ecology book. Fantastic. So which book shall I take next? Well, there's a whole bunch here which I call movement stability and low back pain. The essential role of the pelvis, integration of research and therapy. So what about this?
Well, this is a whole series based on a series of
Congresses?
congresses that are still
I think that's what we see here.
Yeah, and
that's the very first one.
That's the first one.
Okay, so here we are. That's the very first interdisciplinary World Congress on Low Back Pain and its relation to the sacroiliac joints, November 5th, 6th, 1992, University of San Diego, California. And that's the part, and this series of this interdisciplinary World Congresses on Low Back Pain, they're still they're still
every 3 years
they're still going on. Yes. I think the next one is like either this year or the next year. It's something like this. It's going to be number,
I think I believe it's this year, and I think it's in Germany.
Okay, I see.
I believe.
So, and here we are. So as we look at the program here, the tensegrity system in the pelvis, theory and treatment of hind quarter pain. Dr. S.M. Levin. So I like this, the hind quarter, I haven't heard you using this terminology later, but you might as well elaborate on this.
Well,
and by the way, another interesting thing is that in the same session here, you are in the same day together with, Andrew Fleming, towards better understanding of the etiology of low back pain, and then with Serge Grakovetsky.
Right.
So who speak the problem of non-invasive assessment of spinal function, a system for automatic diagnosis of the mechanical etiology of spinal disorders.
And I believe McNeil Alexander was in that program too.
Maybe so.
Somewhere or other, and he was the world's leading expert on movement. Did a lot of work on kangaroo jumping and structure like that, but is recognized as the world leading expert. He recently is deceased a year or two ago.
Okay, but then if we look at this, so let's just get into that. So this is these are the series and how was that related to the Biotensegrity introductions and so on.
Right. So
these are different editions.
Yeah, they're different.
By Churchill Livingstone. And let's have a look here. But at the time, were you using the term Biotensegrity in the books, or you were mainly?
I didn't use the term in the books because it was, but I had already started using it. Yes, but it wasn't in the book. I wasn't using it in that.
Broad sense. You were using
because I was usually I was asked to talk about a section or a part like the pelvis or the spine or the neck or the knee. So I wouldn't address it in a broader term, but I think I introduced it in the late 80s, someplace or other.
Okay, but this type of congresses, what you would do, you would actually, sign up for the Congress, depending on where these guys were actually focused at.
Right.
So if this was a pelvic Congress, you would say
Exactly.
the tensegrity system in the pelvis. If that was their low back, it would be tensegrity in the low back.
Yeah, I have one here on the shoulder too. On some Congress I do. It's somewhere in here, the shoulder, and here's one in mechanics of medicine and biology. I think I did that one in Paris. I think that was also I did on the shoulder. So it would depend on in a hand one I'd do some one on the wrist. Wherever I was, whatever topic was, I submit a paper. Most of these are jury, so you just can't just go to the meetings. you get a jury.
The scientific committee.
Right.
So in order to be able to get into
Right.
the Congress,
So
you have to submit it to scientific committee,
Right.
which then kind of scratch their head
Yeah.
and said whether you're worthy of being, in the pantheon of the scientists there.
Exactly. So you're, so what you submit is screened. So I would submit, depending on if there was a particular theme of any one of these things, I just throw in what, I write a paper on that theme. That's all, and submit it.
Okay, so
it was essentially when I got there, the poster or presentation was pretty much the same. It was just focused.
Okay, so the intro, the main bulk of it, and so on would be, and the outro would be the same, but then you would just change the application towards a particular area in the Bible.
Exactly.
Okay, I see. Okay, so what else we are looking at? Okay, so these guys, they also did another book here, which was on the, not only on the cervical pain. Wait, this is the back pain. Is it the same? No. This was the musculoskeletal medicine. This
is another one. This is a different book from by Patterson and Byrne.
And here, what was?
It was the same kind of thing, but it was just again a focus on one particular area. This one might be the one I did the neck thing on.
You mean this?
This one was the more general.
Here, the space truss is that's the one. It's the space truss as a model for cervical spine mechanics, a system science concept.
All right, so I got all the catchwords right there.
I see. So what at the time that was okay. That's the demonstration. The arm as a liver system. The drawing here. Well, you were talking about the dynamic nonlinear systems are self-generating with order arising spontaneously in those systems. There is self-similarity or symmetry across scale, so that at any level of magnification or scale, the structure is similar. As in the hexagonal tiled floor, there is a recursion with pattern inside pattern. Well, I must say that you were really throwing some serious stuff there, right? In terms of
most of the time, nobody understood. Most of the group I talked to didn't understand what I was saying, or weren't interested because they're clinicians doing something. But I was giving them the basic science. Yes.
No surprise, and no surprise here.
And for the most part, even the engineers didn't understand what I'm talking about, because I'm talking non-linear terms and they're talking about linear things.
Okay, and here's a quote from you. Given a bioengineer the problem of calculating the force generated by the biceps muscles when loading with the weight in the hand, and he constructs a free body diagram with the forearm as a simple lever and the elbow as a 1 degree of freedom hinge. Figure 27.1. This is a standard reductionist approach to biomechanics, which ignores the fact that what happens in the elbow or any other joint has macro and micro consequences that affect the whole body, which in turn affect the forces generated in the biceps muscles. So, as I read this here and I look back at where, science was overall in in the early 1990s, so because that was really before the widespread of the computer, that's why that was before the whole, network understanding and so on. So those things were really, like the system science, they were really mostly for theoretical biologists, I would say.
Yes.
So people who would be zoologists in training, or the ecosystems in training, and they would be detached from their everyday life in that respect, let alone from clinical experiences. So,
right.
So if you were to put an orthopedic surgeon and a theoretical biologist in the same room, you had to put them at the same table and give them the same wine, right? So then they would have something in common to talk about.
Right.
Okay, so this is...
Well, if you go back, the system scientist is looking at the whole structure, like the ecologist, you're looking at the unit, the whole body, the whole pond, the whole ocean. Right? So you're looking at the whole thing. In biomechanics, they were doing exactly opposite that. They were doing free body diagrams where they would detach the arm from the body and just study the arm, or they detach the leg from the body and just study the leg without any relationship to the rest of the body.
Well, technically speaking, operating under the assumption that those contributions were negligible.
Yes.
So that's really the central point here, right? Is that, of course, we're talking about the people with, degrees, with people, with PhDs and so on. So that's, in that sense, that obviously there, at some point, there would be certain lip service saying, well, of course, we are, any book on biomechanics would actually start with the whole kind of paying homage to the integrity of the organism, and that everything has to be treated in the proper way, and it's like everything is connected to everything. But when it comes to the practical things, the operating working assumption there is that the impacts outside of this free body diagram are negligible. So for the sake of clarity of the model, you can isolate this particular area and assume that those impacts are too small to be, like causing any perturbance or any distortion to the model in hand.
That is their assumption, yes. But when you start looking at the real life situation, it isn't that way. And when you look, and the Biotensegrity model, of course, is a conceptual of the functional unit, the whole body. So, but because if anyone takes the time to just study, and there are articles in the orthopedic literature on this too that question it, so I wasn't the only one questioning by any means. But there is, that it's clear, for instance, that many muscles in the body cross more than one joint. And if you cut the arm off at the shoulder, all the muscles that cross both the elbow joint and the shoulder joint, and there are several, that cross both the elbow and the shoulder joint, are lost in the concept. So they're stuck because they got things that are coming from the outside that they're not calculating or understanding at all.
So in that sense, if we take it as another kind of entry into the tensegrity model, probably the first strong statement that you would have there is that you can, the assumption about the negligible or negligibility of the system engagement in a particular part of the body, that assumption is too arbitrary. So it's actually the assumption which throws the baby with the bathwater.
Yes, and again, I wasn't the only one saying that. There were some well-known, higher up orthopedic surgeons and biomechanics people who were saying the same thing, but it all at the same time ignoring it. They would say it, but they'd still go on and do this free body diagram concept.
Well, because that's understandable in a way that you see the lure of the well elaborated in like toolbox, the mathematical toolbox that has been shaping up for at least 200 years prior. It's like you have pretty much, it's a plug and play. Everything has been pre-made and pre-built and so on in their in the mechanics of the man-made objects. So it's very tempting to just kind of plug it in and change this interpretation. So whilst the problem, I think that one of the main problem with the tensegrity model is that it's incalculable. You cannot calculate the things numerically, and in that respect, prior to the growing sort of algorithmic understanding of the mathematics, which only emerged in the last, say, 10-15 years, and for this we might also to get some, I'm able to get this mega ultra book, this Stephen Wolfram, A New Kind of Science, right? So you see, that's also the book that has been very controversial and 20 years ago. But the thing is that this is a person who's been probably the most vocal in articulating the algorithmic approach to the mathematics. But when you were doing this stuff, well, that was really completely predated, right? So it's
I didn't know about algorithms at all. I'm just, I'm an orthopedic surgeon doing my simple thing and observing what I see, and trying to understand what I see.
So in that sense, we come into this dilemma, which probably, every scientist or any person who is interested in understanding how the world works or how the nature works is facing. So what do? Are you going with convenience and kind of prefabs and then just plug and play, and then it's one journey, right? Or whether you're really saying, well, I'm not comfortable with the ready answers and I'm willing to go into the discomfort of the unknown and just kind of throw in certain potential exploration avenues, even though they are not comfortable to begin with because they don't yield readily to the numerical answers. So that's probably the way that as I'm sort of listening to you and what I was thinking before, I think that's probably the greatest challenge that we are facing overall with the integration of the tensegrity model in the understanding throughout the biomechanical community. It doesn't yield itself readily to the numerical processing. Or if you are using the numerical processing, like in the engineering books, then this model becomes nothing special. So it's just kind of, just one of the classes of this particular twisty thing. So that's a very interesting thing that you started using that language and you started using these explanations really like a long time ago, and it's not a surprise that that was well before this language sort of came into, well, at least not really mainstream, but at least kind of more up-to-date science. So, what else do we have here? Textbook of musculoskeletal medicine.
Oh, this is actually
Michael Hudson and Richard Ellis.
Yes, these are
Oxford.
Yeah, these are MD physicians doing manual medicine type of work, mostly in England, but they're from England, of course. They're from Oxford.
Oxford
But I have
Medical
a section
Publications, and this is from 2006. Oh, actually, it's not that long ago here.
Yeah.
Okay, so and anything interesting?
Well, actually, I have one of my longer bits in here.
Okay, I see.
So it really it really covers a lot of territory. As I said, mostly like I did the one on the pelvis and things, and I sneak in everything else. This one, somewhere around there we can find it. Here is 223, 225, 86. Oh, it goes from page 69 to page 80.
Okay.
So that's a lot of.
Okay. Here we go. Isn't it is this guy from the Grant's method? No? No, this is not the tensegrity.
Yeah.
Okay, tensegrity, the new biomechanics, Stephen Levin. So this is the textbook of musculoskeletal medicine, Oxford Medical Publishing. Tensegrity, the new biomechanics. Well, okay, the anomalies, the evolution of the structure. Oh, biotensegrity. That's where the word biotensegrity already comes in. If we accept the precepts of most present-day biomechanical engineers, 100 kilo weight lifted by your average competitive weightlifter will tear his erector spinal muscle, rupture his disc, crush his vertebra, and burst his blood vessels, according to the calculations of Grakovetsky made in 1988. So that's really, well, that's a lot of illustrations here.
Yeah, that's right.
So, and Grakovetsky article, Grakovetsky. So that's from his spinal engine book. So, and I saw it somewhere here.
That's around.
Actually, it's just behind behind me here. So we'll probably get into it because he's a very interesting character, and you can see that one can see that you really did study this book very thoroughly. And we also just seen that right back here in the no, it was the other one back in 1992, as early or maybe even before. You started meeting him, or you met him at the different congresses around where he was.
Dr. Gretzky and I have known each other since 1982.
Oh, it's even okay. So
I met him in Toronto at a International Society of Study with Lumbar Spine in 1982, where I gave my first paper to a spine group.
Okay.
The paper before that was to a mechanics group, essentially.
This one, okay, right. because the first one was engineering and medicine and biology. Right. Okay, I see.
This one, the next one I gave was a year later at the International Society of Lumbar Spine, and that was to clinicians primarily. We would meet almost every year at one or two meetings.
Okay, so that's
because we were crossing. Since he's an engineer, he'd be going to engineering meetings and spine meetings, and since I was an orthopedic surgeon interested in the engineering, I would be going one of the other two. So we were often cross paths.
Okay.
And so we had regular discussions, and then we've continued it online over the years. So we've had regular discussions about this ongoing.
Okay, so I guess we might take a break now, and we still have a lot of books to cover. So because we wouldn't be able to fit all of those in one episode, but I must say that this is really indeed, that's where we see the new language. And here it is, Grant's tension model. Here it is.
That's right. There it is.
Yeah, that's the one.
Right.
Fantastic. Okay, so let's zoom onto it and just memorize this. But is it the way that it was in his book?
I'll show you it in his book, yes.
Or redrawn by you?
It's redrawn. That's redrawn.
Yeah, okay, but it says Grant's tension model.
Yeah.
Okay, I see. Wow. Okay, so you've got the whole, you've got the entire sort of fanning of the pectorals there, and the shoulder blades and so on. So that's really, that's quite clearly a tensional model here.
Yeah, that's right. That's copied after Grant.
Okay, great. So we're taking a break, and we are getting ready for the continuation of this book series, and digging into the history and the entire connection between the tensegrity and the evolution of the musculoskeletal medicine, the spine studies, and everything else. Okay, thank you very much, and we'll see you in the next episode.
All right.